In the previous sessions, we talked about artery supplying the posterior fossa. Today, we'll be discussing veins supplying the posterior fossa. These veins are divided in four major groups, depending on the area said to supply: superficial veins, deep veins, brainstem veins, and the bridging veins. Superficial veins are further divided on the basis of the superficial surfaces that they supply as tentorial surface, petrosal, suboccipital surface, and petrosal surface. Deep veins travel in the group of deep veins travel in the cerebellum mesencephalic fissure, cerebellomedullary fissure, and the cerebellopontine fissure. They also have the veins of the superior, middle, and inferior cerebral peduncles, respectively. Brainstem, the veins supplying the brainstem are collectively grouped as brainstem veins, and the draining veins, the major veins that drain these territories, are termed as bridging veins, as Galenic group, Tentorial group, and the Petrosal group. Today we'll be talking about superficial veins and deep veins as section 1 of this lecture, and we'll talk about brainstem veins and bridging veins in the next session of this lecture. Superficial veins, as we discussed, are grouped on the basis of the surfaces that they supply as tentorial, suboccipital, and petrosal surfaces. These surfaces are bordered as parallel to the major venous sinuses with superior petrosal sinus dividing the tentorial surface and the petrosal surface, transverse sinus dividing the petrosal surface. Transverse sinus divides the tentorial and suboccipital surface, and sigmoid sinus divides the petrosal surface and suboccipital surface. For the veins supplying the tentorial surface, this is further divided into superior vermian veins and superior hemispheric veins, so corresponding to the areas that they supply. Superior vermian veins are grouped into anterior or ascending group, or posterior or descending group of vermian veins. As you can see in this picture, that they have been color coded according to the according to the drainage system, with green as they drain into the vein of the Galen, with blue as they drain into the superior petrosal sinus, and red indicate those that drain into the tocula. The anterior or ascending group of vermian veins originate near the tentorial fissure and join near the apex of the cerebellum. They have tributaries from vein of the cerebellomesencephalic fissure, tectal veins from the quadrigeminal pate, and also hemispheric branches from the medial part of the hemisphere. Whereas posterior or descending group originating near the tentorial fissure terminate in the tocula and course posteriorly. Here we can see in this picture the anterior superior vermian vein draining towards the vein of the Galen, and the posterior or descending vermian vein draining towards the tocula. This is the tentorial ischemic diagram. This is the posterior view of the brainstem, here we can clearly more see this as the superior vermian vein and superior vermian vein supplying the vermis, anterior part of the vermis of the tectorial surface, and tectal vein joining this and draining into the vein of the Galen. This is a mid-sagittal view in which we can again see the superior vermian vein draining into the vein of the Galen. This is a dissection of the tectorial surface in which we can observe the superior vermian vein draining into the vein of the Galen. This is a dissection of the tentorial surface, in which we can also again observe superior vermian vein, which goes to the vein of the Galen, where the right side of the tent has been removed, and here again superior vermian vein drains into the towards the vein of the Galen, supplying the anterior part of the vermis. The lateral surface or hemispheric surface of the tentorial surface is supplied by superior hemispheric veins. This is divided into anterior, posterior, and lateral group. As the name suggests, the anterior group drains the anterior part and they join superior vermian vein. They may join superior vermian vein or drain through the cerebello-mesencephalic fissure, the veins in the cerebello-mesencephalic fissure. The posterior group forms a common trunk with the inferior hemispheric veins to enter the tocula. The inferior hemispheric veins come from the suboccipital surface behind the tocula and join towards the tocula. The lateral group drains into the superior petrosal sinus. In this schematic diagram, we can see that the lateral superior hemispheric veins draining towards the superior petrosal sinus, and here we can observe the anterior subhemispheric veins draining towards the superior vermian veins. This is a dissection of the tentorial surface in which the right side of the tent has been removed to expose the veins of the tentorial surface. Here, both sides of the tent has been removed. The superior hemispheric, this we can observe that the superior hemispheric vein draining towards the tocula. On this side, and these veins are being joined by the inferior hemispheric veins and draining towards the tentorial sinus. The drainage of the suboccipital surface is similarly divided into inferior vermian veins, which supplies area of the vermis, inferior hemispheric veins, and it also involves superficial group of tonsillar veins. The inferior vermian veins receive its tributaries from tonsil, from tonsils, vermis, and adjacent part of the hemisphere, and posterior medial part of the tentorial surface. These ascend along the vermohemispheric fissure and terminate in the straight. They may terminate in straight sinus, transverse sinus, or tocula, and may cross vermis to terminate in the inferior vein on the opposite side, often forming an anastomotic vein. Here we can see that inferior vermian vein draining into the transverse into the straight sinus. This is a dissection of the suboccipital surface in which we can observe inferior vermian vein from the both sides going towards the tentorial surface. This is an enlarged view of the same dissection in which the inferior vermian vein from both sides can be observed. The hemispheric area of the suboccipital surface is drained by the inferior hemispheric veins. They are grouped as orientation as longitudinal or transverse. They are divided into four groups: superior medial, inferior medial, superior lateral, and inferior lateral veins. With superior medial covering the major area, their passage as longitudinal, they may drain into superior veins, may drain into toccular, tentorial sinus, or the inferior vermian vein. The inferior medial veins may drain into inferior retrotonsillar or inferior vermian veins, and superior lateral hemispheric veins drain into tentorial sinus, and inferior lateral veins drain into the anterior hemispheric veins. This is a view of the petrosal surface of the cerebellum, which we'll discuss in the next slides. Another branch of the inferior hemispheric veins is retrotonsillar veins. They are divided in superior and inferior retrotonsillar veins. They originate from the superior poles and the inferior poles of superior and inferior poles of the tonsils. They also receive their tributaries from the medial tonsillar veins and the lateral tonsillar veins, and they drain to form in drain into the inferior vermian vein. This is a mid-sagittal section in which we can see inferior vermian vein going towards the tocula, and we can also see the medial tonsillar vein and inferior tonsillar vein going towards the inferior vermian vein. In this dissection of the suboccipital surface, we can observe the inferior hemispheric veins going towards the inferior, draining into the inferior vermian vein, and same goes towards the same is on the right side. The petrosal surface of the cerebellum lies against the posterior margin of the petrosal bone, petrosal ridge. It is supplied by the anterior hemispheric veins. These veins arise near the borders, and pass anteriorly to converge on the cerebello-pontine fissure. It is divided into superior, middle, and inferior groups, with inferior group being the largest of all. They converge on caudal part of the cerebello-pontine fissure to form a common trunk, and middle anterior veins converge on apex of the cerebello-pontine fissure and joins common trunk of the middle group near flocculus, forming vein of the cerebello-pontine fissure, and passes to superior petrosal sinus. Here we can see anterior hemispheric veins going towards the cerebello-pontine, traveling in the cerebello-pontine fissure. These are the superior anterior hemispheric veins. These are the middle anterior hemispheric veins. This is an anterior view in which we can see the anterior hemispheric veins traveling in the cerebello-pontine fissure and joining the vein of the cerebello-pontine fissure, draining into the superior petrosal vein. This dissection is after removing the arteries of the posterior fossa. We can observe that anterior hemispheric veins are traveling in the cerebello-pontine fissure, similarly on the other side as well, and they drain into the superior petrosal sinus. Deep veins course in the fissures between the brainstem and the cerebellum. They are divided into the veins into three groups: cerebello veins lying in the cerebellum mesencephalic fissure, group of veins lying in the cerebello medullary fissure, and group of veins lying in the cerebello-pontine fissure. We have to keep in mind that the vein of cerebellum mesencephalic fissure and the veins of the superior cerebellar peduncle both lie in this region. There are two different groups lying in this region. It is related to the superior part of the fourth ventricle roof. Similarly, the veins lying in the region of the cerebello-medullary fissure are different than the veins of the cerebello-medullary fissure. This group consists of the veins of the cerebello-medullary fissure and veins of the inferior cerebellar peduncle. The group of veins lying in the cerebellum-mesencephalic fissure are divided into four groups. As we just talked about it, vein of the superior cerebellar peduncle. It also has pontotrigeminal veins and the lateral mesencephalic veins. So, vein of the superior cerebellar peduncle drains It has its tributaries from dentate nuclei, superior cerebellar peduncle, and walls of the cerebellum mesencephalic fissure. It originates near the lateral margin of the superior cerebellar peduncle. It crosses the peduncle and then upward on and goes upward on the peduncles, join near the rostral tip of lingula, and forms vein of the cerebellum mesencephalic fissure. As we can see here in the green shade, we discussed previously that those veins that are shaded as green drain into the vein of the Galen. This is the vein of the superior cerebellar peduncle, traveling from lateral border of the superior cerebellar peduncle upward and draining into the vein of the cerebellum mesencephalic fissure. In few cases, there are two separate veins. They separate veins from the separate cerebellum mesencephalic fissures draining from the superior cerebellar peduncle, which join the vein of Galen. Another group of veins that travels in the cerebellomesencephalic fissure is the vein of the cerebellomesencephalic fissure, which is also known as the precentral cerebellar vein. It arises, as we discussed, it arises deep in the cerebellomesencephalic fissure from the union of veins from the superior cerebellar peduncle. It crosses the quadrigeminal cistern and it drains directly to the vein of Galen, or maybe through after joining with superior Vermian vein. It receives its tributaries from the posterior aspect of the midbrain and walls of the cerebellomesencephalic fissure. In this dissection, we can see that veins of the superior cerebellar peduncle are going upwards and they join to form the vein of the cerebellomesencephalic fissure. And here we have removed the arteries in which we can clearly see the pathway of the vein of the superior cerebellar peduncle coming from the lateral surface of the superior cerebellar peduncle, traveling upwards and joining to form the vein of the cerebellomesencephalic fissure, which will go upward and join the vein of the Galen. This group also contains of pontotrigeminal vein and tectal veins. Pontotrigeminal vein arises on the surface of the middle cerebral peduncle near the interpedicular sulcus. We can see that here. It passes above the trigeminal nerve and drains directly into the superior petrosal sinus. The proximal end of the pontotrigeminal vein anastomosis with vein of the superior cerebellar peduncle and lateral mesencephalic vein. It also consists of a group of tectal veins. These originate on or near superior and inferior clavicular. They course upward in the quadrigeminal system to drain into the cerebellomesencephalic fissure, or they may drain into superior Vermian or internal cerebral vein, or directly into the vein of the Galen. They are often anastomosed with vein of the superior cerebellar peduncle and pineal, lateral mesencephalic, or basal veins. The group of veins crossing the cerebellomedullary fissure consist of the veins of the cerebellomedullary fissure itself and veins of the inferior cerebellar peduncle. These drain into the cerebellopontine angle through the communication between the cerebellomedullary and cerebellopontine fissures. So first we talk about veins of the cerebellomedullary fissure itself. They originate on lateral edge of the nodule and uvula. They course laterally near the junction of the inferior medullary velum and thylakoidea. As we can see on the both sides, they may course ventral to the flocculus, or they may course dorsal to the flocculus. If they course ventral to the flocculus, they'll join lateral medullary vein or vein of the inferior cerebellar peduncle or pentomedullary sulcus, and which will eventually join vein of the middle cerebellar peduncle, as we discussed in the previous slide. If it courses dorsal to the flocculus, it will terminate in the anterior hemispheric veins, which were the surface veins that we discussed previously. or vein of the cerebellopontine fissure to eventually join the middle cerebral vein of the middle cerebral peduncle. The veins of the cerebellomedullary fissure drain inferior medullary velum, tela choroidea, periventricular white metal, dentate nuclei, antero-inferior surface of the biventral lobule, and the inferior vermis. Here we can see the veins of the cerebellomedullary fissure traveling between the inferior medullary velum and the tela choroidea and traveling laterally. This group also consists of the vein of the inferior cerebellar peduncle. It courses on the peduncle parallel and caudal to the inferior lateral margin of the fourth ventricle. This we can see here. And the vein of the cerebellomedullary fissure that we discussed previously lies here. It goes inferiorly on and joins each side below the obex to form median posterior medullary vein, and superiorly it passes below the lateral recesses and joins the vein of the pontomedullary sulcus, or it may join lateral medullary vein and drain into the vein of the middle cerebral peduncle. It drains the posterior and lateral aspects of the medulla, tela choroidea, choroid plexus, inferior part of the fourth floor, lateral recess, and glossopharyngeal and vagus nerves. This is an interior view of the petrosal surface in which we can see the cerebellomedullary veins of the cerebellomedullary fissure also consist of the supratonsillar veins and the choroidal veins. As the name suggests, it does not drain the supratonsillar surface. It courses in the cerebellomedullary fissure near the superior pole of the tonsil, originates in the deep nuclei and white matter of the cerebellum, and drains inferior half of roof of the fourth ventricle. It courses along the inferior medullary velum and drain into the cerebellomedullary fissure or inferior vermian vein. Here we can see supratonsil medial and lateral supratonsillar veins draining into the cerebellomedullary vein of the cerebellomedullary fissure. This group also considers the choroidal veins. In choroidal veins drain tela choroidea and attach to choroidal plexus, and these are tributaries of cerebellomedullary fissure and inferior and veins of the inferior cerebellar peduncle. Cerebellopontine fissure consists of the veins of the cerebellopontine fissure and veins of the middle cerebral peduncle. Veins of the cerebellopontine fissure are the largest vein draining the petrosal surface. They are formed just rostral or caudal to the flocculus by union of the anterior hemispheric veins. As we can see here, it courses over the cerebellopontine fissure and crosses the subarachnoid space rostral to the 7th, 8th, and 5th nerve, and then joins the vein of the mid cerebellar peduncle, joins the middle cerebellar peduncle and the pontotrigeminal vein, and which eventually drains into the superior petrosal sinus. Here we can see the anterior hemispheric veins draining into the vein of cerebellopontine fissure, which drains into the superior petrosal sinus. This views enlarges the left side of the petrosal surface. Here we can see the anterior hemispheric veins, superior and inferior anterior hemispheric veins draining into the vein of the cerebellopontine fissure, this is also superior hemispheric vein, which is drain into the superior vein of the superior petrosal sinus. This group also considers the vein of the middle cerebellar peduncle. It originates in the fossa above inferior olive and is formed by the union of vein of the pontomedullary sulcus and the lateral medullary vein or vein of the inferior cerebellar peduncle. It drains directly into the superior petrosal sinus, as we can see here. It passes either between origin of eighth nerve or focus or eighth nerve or the facial nerve. It receives drainage from the drainage of the rostral half of medulla and inferior half of the fourth ventricle and lateral surface of pons. Here we can see the vein of the middle cerebral peduncle forcing towards the superior petrosal vein. This is dissection of a supra-angle approach in which the cerebellum has been removed to expose the deep parts of the cerebellum. This just to overview, just in a schematic diagram in which the tentorial surface has been exposed. Here we can see the superior hemispheric and superior Birmian veins draining into the vein of Callan and endotocula. This is the schematic diagram of the suboccipital surface in which vein of the inferior hemispheric veins and inferior Birmian veins can be observed. Thank you.
Thank you, Dr. Priyanka. I know it was unfair to, this should have been covered in maybe 3 sessions, what you just explained now. And venous anatomy is not as fascinating as the arterial anatomy and complex as well. So now I would request Dr. Keel Pabani to simplify what you've just explained. And, I request all participants to ask questions because this was a difficult session, even for the presenter herself. Too many names, too many drainage. So, Dr. Priyanka, Dr. Keel, can you, if you have a presentation to share, Dr. Priyanka, can you stop sharing? Dr. Pabani, do you have a presentation?
Can you hear me now?
I can hear you now.
Okay, give me 1 second. Let me just.
So till Dr. Pabani joins and opens up his presentation, I know this was a difficult day for everyone, considering the complexity of the venous system in the posterior fossa. So do ask questions. Dr. Pabani is here for you guys, and he's more than happy. He will be more than happy to answer you guys. So you can use the chat box. I request Dr. Pabani to just simplify what Dr. Priyanka has already explained.
All right, let's see.
Yeah, we can see your screen.
Awesome. Okay, great. Okay. All right. And Dr. Saad, at any point in time, if my voice, if you can't hear me, just let me know because I'm having some issues with my laptop and where I just go on mute automatically. So so forgive me for that. So Assalamu alaikum, everybody. This was a great talk. And as Dr. Saad mentioned, that this is an exceedingly difficult and an extensive topic, obviously. And oops, I don't know how to get rid of this. So it's obviously very extensive and it requires a lot of detailed study. But the reality is, in posterior fossa veins, that you have a lot of variation and variability, and obviously it is almost impossible to know each vein in the posterior fossa by heart, and then understand. I think the more important thing is to understand what their anatomical location is, and what territories are they draining, and what is the clinical implication of those veins. because you will see as we progress in this talk is that it is more important to know their anatomy. And when I say anatomy, I mean like their territory that they drain, and how are those veins implicated in certain clinical conditions, because more often than not, if you're doing surgery on somebody or doing an endovascular procedure, that's when those veins become very relevant. So the purpose of this slide is to basically show you this is a right vertebral artery injection, this is a left vertebral artery injection, and you can see all these veins in the posterior fossa right here, right? And you can see that this is the vein of Galen and the straight sinus right here. This is the cerebellum right here, and you can see this wealth of veins in the posterior fossa. This is all the venous phase right here. This is the occipital lobe up here, obviously, and different injections can reveal different veins, and so it's obviously they're so small and they're so tiny that it's hard to know each and every one by name. So the rule is it's a variability, right? As I've mentioned initially, that there's a lot of variation. No two patients that you will see will have the exact same venous drainage pattern. The entire posterior fossa venous system can rarely be visualized from one-sided vertebral artery injection, right? So that's why I showed you the two-sided injections. And if I go back, you can see the right-sided injection reveals veins in a different way versus the left-sided injections. And then third, anatomically, you can only visualize. One second. How do I get rid of this? There you go. Angiographically, you can only visualize the veins of the corresponding arterial territory. So if you inject the right vertebral artery, you are only going to see the arterial distribution of the right vertebral artery, and then correspondingly, you will see the venous outflow from that territory only. And then most importantly, it is very vital to understand the anatomical location of the veins relative to the brainstem and the cerebellum. Naming is not entirely critical. You will automatically be able to generate the names by yourself if you know where the vein is located, right? So if the vein is located in the cerebellomedullary fissure, and if you know where that fissure is, then the vein in that fissure is a cerebellomedullary vein. If the vein is located on the lateral aspect of pons, then it's a lateral pontine or a transverse pontine vein, right? So there's no this is not rocket science. I mean, people say it's brain surgery or not brain surgery, but this is definitely not rocket science. So I think if you really want to make things easy for yourself and you make your life easy, I would focus more on understanding the anatomy, relative anatomy of the veins to the arteries, and because we all know the arteries, but understand the relative anatomy of the veins to the arteries and the brainstem and the cerebellum, and automatically you will be able to name the veins like the back of your hand. So what are some of the general rules of the posterior fossa anatomy? So this is a lateral view of a posterior fossa circulation. However, the vertebral artery here and the basilar artery have been masked, whereas you can see the venous phase right here, right? And so when you look at this picture, obviously that the angiograms, and that's the other thing. So I would definitely recommend that all of the neurosurgery, and even if there are non-neurosurgical residents here or trainees, spend a lot of time looking at the angiograms, because unfortunately, because of the advent of CTA and MRI and MRAs, we have lost the skill to visualize and then understand and interpret the angiograms. But it is pretty much the only dynamic study that we have. And that can give you a lot of information about the hemodynamics of the brain. So when you look at the angiograms, try to understand and visualize where the brainstem would be. So something like that, when you're looking at the angiograms, sort of create an understanding where let's say the thalamus, the midbrain, the pons, and the medulla would be in relationship to these blood vessels, because in a DSA, all the neural structures are subtracted and you're only seeing the blood vessels, obviously. And so it's really important to be able to visualize all this and understand it. And then, if any of these structures are displaced, you know that's where the problem is, or that's where the pathology is, or that's where the tumor is. And so by looking at this right now here, obviously you can see that the basilar artery is obviously located. You cannot see the basilar artery on this image, but you know that the brainstem has to be right here, because your knowledge of anatomy will tell you that the basilar artery is anterior to the brainstem, or anterior to the pons rather, right? And the midbrain is going to be somewhere around here, because the PCAs will circumvent or go around the cerebral peduncles. So similarly, as you know that where the basal vein of Rosenthal and the vein of Galen will connect into the straight sinus, is where your tectal plate would be. And you can see your choroid plexus right here, and so that will determine where your choroidal veins would be. The foramen of Monro is going to be in this area, so that's where your third ventricle is below here. Your lateral ventricles are going to be above here. You have a vein that is in front of the pons and in front of the basilar artery, so that will be automatically an anterior pontine vein. Similarly, you have a vein that is on the lateral aspect of the midbrain and the pons, so that will automatically become lateral pontomesencephalic vein. So there's nothing difficult about this. So you have a vein that crosses transversely or across the pons, that automatically becomes transverse pontine vein. However, it's hard to say because we do not have the AP projection here. This could easily be the continuation of the superior petrosal sinus. So what I'm trying to tell you is, again, you don't have to focus on each and every little vein, because I don't think anybody can name all of those, but just understanding their anatomical significance will help you moving forward. And so as was being discussed in the presentation earlier, there are obviously several veins, but generally if you divide these veins, let's say if we're talking about the cerebellar veins here, if we divide them into certain groups just based on the surface of the cerebellum you're talking about, the life would be much easier. So for instance, if let's say if this is the cerebellum right here, and here you have the superior petrosal sinus, here you have the superior sagittal sinus plugging in, you have bilateral transverse sinuses, transverse sigmoid junction here. The veins which are on the inferior aspect of the cerebellum will obviously plug into the distal aspect of the transverse sinus or the transverse sigmoid junction, whereas the ones on the tentorial surface of the cerebellum or the superior surface of the cerebellum will drain automatically into either the vein of Galen, the straight sinus, or on the superior aspect of the transverse sinus. Similarly, on this picture right here, as you can see, if there are veins, this is superior petrosal sinus right here, and IPS, right, inferior petrosal sinus right here, and you can see all these veins which are on the lateral surface of the cerebellum, which you can easily call them as lateral cerebellar or lateral cerebellar cortical veins. The more medial they will drain into the more medial aspect of the transverse sinus, and they will drain into the more lateral aspect of the transverse sinus, the ones which are more laterally located. The ones that are superiorly located, as I said, will go into the inferior sagittal sinus or the superior sagittal sinus or the vein of Galen, and so on and so forth. So right here, once again, sort of depicting the same what I was alluding to earlier is if you look at these AP projections, and this is the venous phase, obviously, you can see that all these veins are the cerebellar veins, which are essentially draining. The medial ones are draining in the medial transverse sinus. The lateral ones are draining towards the lateral transverse sinus. You can see where the outline of the cerebellar hemispheres right here, and the vermis would be somewhere in the cerebellar intracerebellar hemisphere fissure would be somewhere in the middle. And so, as I said, no two patients will have a similar venous anatomy alike, and so you just have to kind of, look at the veins and then decide what's important to you for your surgical approach or for your pathology. Obviously, a lot of people talk about Vermian veins because, a lot of times we do these transvermian approaches for brainstem pathologies or to get into the floor of the or get to the fourth ventricle, excuse me. And so obviously you can see these superior Vermian veins and superior Vermian vein and the inferior Vermian vein right here. And you have a superior Vermian vein that drains into this very important vein that we talk about is a precentral cerebellar vein. And the reason we talk about this is, well, let me tell you this right here. So here's your precentral cerebellar vein. You can see this on the MRI. You have a lesion here in the superior cerebellum. Here's a good visualization of the precentral cerebellar vein. But the reason this vein is important is because this is the one that you sacrifice whenever you're doing a supracerebellar infratentorial approach. So whenever you're trying to approach pathology in the pineal region or by the tectal plate, by the colliculus, this is the vein that obviously here in the diagram it shows it's already been cut, but this is the one that tethers the cerebellum. And this is the vein that after you cut very dense layers of arachnoid here, you get to this vein, you divide it, and you're able to pull the cerebellum down to expose this area right here. And you can as much as expose the posterior part of the corpus callosum or the splenium right here, the pineal region and the colliculi. So knowledge of this vein is important because if you're not careful, you can tear this vein from the vein of Galen directly, and the vein of Galen starts bleeding into your field, and that's basically, it's not going to be a pretty situation for surgery. Moving quickly to the brainstem veins. Let me see, how much time do we have? Okay, not much. So here we have a bunch of brainstem veins, and as you can see, this is like a die cast of the brainstem, and there are a ton of veins here. Again, no point in knowing and remembering all of these, but I'm just going to go over a few, but sort of make a schematic in your brain as to how these veins are arranged. And essentially, as we know, the brainstem is divided into three parts: the midbrain, pons, and the medulla. And so are the veins that basically drain each of these compartments, right? So let's say at the top right here, you have the basal vein of Rosenthal, which essentially go with the travel with the posterior cerebral veins, and then they drain into the vein of Galen and the straight sinus. The vein that's between these two basal vein of Rosenthal and connect these two are basically in front of the peduncles and in the interpeduncular fossa. So automatically they're called the interpeduncular fossa veins or interpeduncular veins. You have this big long channel of conduit, which is essentially, if it's in front of the midbrain, it's called the anterior mesencephalic vein, anterior pontine vein, medullary vein. If you want to name them, you can name them as pontomesencephalic or pontomedullary vein, whatever you want to call this. It's easy. Same thing if the one that's on the lateral aspect, it's the same thing: lateral mesencephalic, lateral pontomesencephalic, lateral pontomedullary vein. These ones are transfers because they are on the lateral aspect of the pons of the medulla. So they are transverse pontine and transverse medullary vein. And then right here, number 5 is essentially your Petrosal vein, and we'll visit that really quickly as well. And here are your superior and the inferior Vermian veins right here, superior cerebellar and inferior cerebellar veins. So right here, when we're talking about brainstem veins, this is an example of a lateral mesencephalic vein, and the reason I put up this picture is because anytime if you're trying to do a brainstem or a pontine or cavernous malformation, sometimes you might have to enter the brainstem from the lateral aspect, so you have to do a retrosigmoid craniotomy. And this vein serves as a good marker because this vein is essentially sitting in the lateral pontomesencephalic sulcus. And if you see this vein, then that basically is telling you that this is a safe entry zone for the surgeon to enter the brainstem because it's devoid of any significant pathways like corticospinal tract or posterior columns or anything like that. And then if the brainstem, if the cavernous malformation comes close to the surface, you can see this vein intraoperatively. You can actually coagulate and divide it because there are so many collateral pathways, and you can enter the sulcus to take the cavernous malformation out. So for instance, this is an arteriovenous malformation that is primarily being supplied by the SCA, as you can see here, and the AICA, anterior inferior cerebellar artery. But then if you look at the drainage pattern right here, it drains deeply into this lateral mesencephalic vein, which you can see here. And then there's a cortical vein that then it drains into the sigmoid sinus right here. So it has both a superficial and deep drainage. The reason, again, I put up this picture is basically just to kind of give you an idea where this lateral mesencephalic vein would be located. So here's your basilar artery right here. The brainstem would be located somewhere around here. And so this is immediately lateral to the pons or the mesencephalon right here. So right here, as I was talking about it, this cavernous malformation, I guess most people would probably approach this from the floor of the fourth ventricle, but you have to be cognizant because you can see a rim of the normal floor of the fourth ventricle right here. So you could easily go through the fissure colliculi and whatnot to get to the cavernous malformation. So some people actually might suggest going from lateral from the lateral mesencephalic sulcus into this cavernous malformation. And a good marker of that sulcus would be this vein right here. So, again, it's named easily enough, as now I'm sure you can all name these veins very easily. And then there's obviously clinical implications to that as well. And then one of the veins that we talk about the most is the Dandy's vein, or because it was first described by Walter Dandy, excuse me. And it's this vein right here in light blue right here, or in green right here. And the Petrosal vein is essentially what connects the lateral brainstem veins to the superior petrosal sinus, which is right here, as you can see. So this is a vein that we see most commonly when we are doing retrosigmoid craniotomy for microvascular decompression for trigeminal neuralgia. And almost universally, most people, so some people will talk about preserving it, but there have been papers after papers that basically tell that you can essentially coagulate and divide this vein with impunity, and there will be no brainstem stroke or cerebellar hemorrhage or anything like that sort. I can tell you in my practices, I've done a few hundred of MVDs, and I almost always take the petrosal vein, and thus far I have not encountered any complications. So, but however, I do remember a couple of cases where the petrosal vein was exceedingly large. It was much bigger than I had anticipated, and I obviously in that case I did not divide it because I was worried that this might be one of the leading or one of the dominant venous drainage of the posterior fossa. And so in that case, we left it alone and we performed the microvascular decompression without disturbing the vein. So, I mean, I did not get an angiogram of that patient, but it is quite possible that that patient's petrosal vein was most likely a very dominant venous drainage outflow and could have caused some kind of a venous infarction in the brainstem or cerebellum had I chosen to take that vein. So essentially, I think this is the end of my talk, but I think it's important to just understand the venous anatomy in relationship to the neural structures and what areas do they drain, and then see if they become involved in any kind of, especially like vascular malformation or tumors, or if they're going to be in the way of your surgical approaches. Thank you very much.
Thank you, Dr. Babani, for this excellent presentation and cases. I mean, you really made it simple. If any participants have any questions, they can use the chat box, but I think they're too overwhelmed with knowledge today. First with Dr. Priyanka, and then now with your beautiful illustrations. I must congratulate you. I mean, they were like, you really simplified what Dr. Priyanka has taught us. If there are no questions, we're already short on time, but if there are no questions, I would like to end the session. Dr. Babani, it was a pleasure to have you, sir. Shows your interest towards education of education neurosurgery, and we'll keep bugging you again in the future. We'd love to have you back again. Thank you everyone for joining. Next week we'll have the second session. Okay, Dr. Pravat has just asked a question. Explain about something about venous, and he wants to know about venous and arterial phases. I think he's a junior resident from Dr. Pravat. Dr. Pravat, you're from India, right? So he wants to know about venous. Explain about venous and arterial phases. Anything in particular that you want to know, Dr. Pravat?
So yeah, I mean, so there are several phases when you're doing a diagnostic angiogram. And just to be respectful of everybody's time, there's an early arterial phase when you first inject the dye. It's basically all about the timing. There's an early arterial phase, there's a late arterial phase, there's a capillary phase, there's a early venous, and then there's a late venous phase. And so in a normal angiogram, you expect when you're doing an angiogram, you expect the dye to run through the artery, through the capillaries, and through the veins, which is what we have all learned through our early days in school and medical school. And obviously what you're looking for is a normal transition time from the artery to the capillary to the venous phase. But in certain pathologies like arteriovenous malformation, there could be early shunting. So you could be seeing arteries and then suddenly some veins start appearing because the blood is shunting through the AVM and not through the normal parenchyma. And so that's what, so here, as you can see, that's why I put up this picture. Here this is the arterial phase where you can see the vertebral artery and the basilar artery, but you don't see any veins here. And this is the venous phase where you're seeing all the veins, but you're not seeing any arteries. So that's what arterial and venous phases are.
Thank you, Dr. Prabhani, for that answer. We'd like to conclude this session. And Dr. Prabhani, thank you again. I wish you best of luck. We'll be doing the next part of the venous session next week. And I'd like to conclude the session. Thank you everyone for joining.
Thank you very much, Saad.
Thank you, Dr. Prabhani.